Bismillahirrahmanirrahim. Assalamu alaikum. A 59-year-old man comes to the office for post-operative follow-up. He underwent a partial distal gastrectomy for a perforated peptic ulcer 3 weeks ago. The patient also received an extended course of antibiotic with the last dose taken 2 weeks ago. For the past 10 days, he has had intermittent abdominal cramps and diarrhea. Symptoms begin 20 to 30 minutes after the patient eats and are associated with nausea, weakness, palpitation, lightheadedness, and diaphoresis. He has no symptom overnight and there is no associated fever or weight loss. Medical history is notable for hypertension. The patient has 20 pack year of smoking history but quiet after the recent hospitalization. Temperature is 36, blood pressure is 130/65, pulse is 80, and respiration are 18 per minute. BMI is 26 kg. On examination, the abdomen is soft and non-tender with normal bowel sounds. The surgical wound is healing well and has no erythema or discharge. Cardiopulmonary examination is normal. Complete blood count is normal. Which of the following is the most appropriate next step in management of this patient? So this is a 59-year-old man. He came to the office for post-operative follow-up. He underwent a partial distal gastrectomy for a perforated peptic ulcer 3 weeks ago. For the past 10 days, the patient had intermittent abdominal cramps and diarrhea. Symptoms begin 20 to 30 minutes after the patient eats and are associated with nausea, weakness, palpitation, lightheadedness, and diaphoresis. So based on these hints, the diagnosis of this question is dumping syndrome. As the name applied, dumping, which dumps the small intestine and the duodenum. And the management for the dumping syndrome is dietary modification. And here the correct option is choice A, dietary modification. So this patient's symptoms suggest dumping syndrome, in which destruction or bypass of the pyloric sphincter occur due to injury to pyloric sphincter, which causes rapid emptying of hypertonic gastric contents into the duodenum and small intestine, which causes shift of fluid from the intravascular space to the small intestine, leading to hypotension, stimulation of autonomic sympathetic reflexes, and release of intestinal vasoactive polypeptides. Management includes small, frequent meals, replacement of simple sugars with complex carbohydrates, and incorporation of high fiber and protein-rich food. Come to the incorrect one, endoscopy. So endoscopy will confirm the post-surgical anatomy but will not contribute to the diagnosis of dumping syndrome. Choice C, reconstructive operation. So a minority of patients with refractory symptom may benefit from reconstructive surgery. Choice D, stool for PCR for Clostridium difficile. So this patient doesn't have any fever or leukocytosis to suggest antibiotic associated colitis. Choice C, upper gastrointestinal contrast X-ray study. So diagnosis of dumping syndrome is based primarily on clinical feature, although an upper gastrointestinal X-ray series or gastric emptying study may helpful if the diagnosis is unclear. Thank you.